Welcome to State of Reform's virtual series, 5 Slides We're Discussing, with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
Hello and welcome to another edition of 5 Slides We're Discussing. I appreciate you joining us and making time here on a busy day, whether you are in Alaska where it's noon or if you are in Texas where it's 3 o'clock. I appreciate everyone carving out time. We've got about 500 folks registered to be with us today with a conversation on how best to build an anti-racist culture, specifically in healthcare, but in America today in general. Before we jump in on our guests here today, I want to just orient you a little bit to what you are experiencing with the webinar here. As you can see on the right, you've got a chat box where you can pose your questions, and you can upvote those so that when you see one that you'd like to prioritize, you can move that to the top of the list and make sure that people aren't asking the same questions repeatedly. I may move those over. You see there's a slot at the top for answered, so I may move some of them over just to organize our time together. But feel free to post your thoughts there, and I will integrate those into our conversation. The other thing I'd say is we'll record this and we'll distribute it on our site at stateofreform.com. As I mentioned, we've got a real diverse audience of folks, and so I think that you should offer your thoughts to what you hear in the Q&A session so that people can understand and better, get a sense of your experience as well. I know we've got a number of legislators participating from a number of states, number of folks in different capacities. Many of our attendees at State Reform, as you know, are pretty senior C-level folks often, and I see some of those folks in our chat thread already as it is. So finally, we're all learning how to do COVID well. Some days are better than others. Sometimes 1 hour is better than another hour in the day. And so we'd love to have your feedback after we are done with this about what works well for you, what doesn't, and also what we might be featuring and focusing on in the future. The fabulous news that I have for you today is that we're joined by Melissa Gonzales, who is in the office of, is in the Chief Diversity Office at Genentech, working on external partnerships. The less than fabulous news is that Dr. Ben Danielson has had to cancel at the last minute for a patient matter, and we think that he should be taking care of patients, and we'll get him back in to be with us at another time in the future. So Melissa, thank you for holding down this fort on your own with us today. Appreciate you being here.
Thank you for having me.
Why don't you orient us first? Tell us about your work and what brings you to this conversation on anti-racism.
Yeah, so at Genentech, we believe in embracing the diverse culture around us. And the executive committee has been really supportive around this initiative and developed a chief diversity office. They named a chief diversity officer, Quita Highsmith, in January, and they invested the resources to build out a specific department to address the inclusive culture within Genentech, as well as the external culture. And so we're heavily vested in this area, and we really want to make sure that we're doing our part to address bias and racism in healthcare.
Yeah, very good. I do see, this is the magic of modern technology. I do see Ben in our chat thread here. And so Ben, if you can hear me, you've got email from me in your inbox. So we'll see if we can figure out how to get you on in the middle of our show here. I want to kind of just jump right in on our first question, again, to reorient folks, or our first slide rather, to reorient folks into the structure of our conversation here. The idea is that we want to use 5 slides, tools in the multimedia age to have a smarter conversation, the kind of which that you would expect from State Reform. And here on this first slide, this is one that I have brought to the conversation, Melissa has brought 2, Ben has brought 2 additional ones. And on this first slide, this is trying to capture a few things. First, the image on the left is from the Boston Globe, where they've done some reporting on how white people have come to this conversation about Black Lives Matter and social justice in the wake of African American men and also women getting murdered by police, and that the response has been different this time, that because of the engagement from white folks. The second image there is a picture of my kids and my goddaughter when we were down at one of our local protests, making sure our voices were heard and that their voices were heard, and that they experienced this moment in our history. And then finally, I thought it was relevant as context, important context, this third graphic on the right of your screen. This is polling data from earlier this decade, showing that when on the topic of gay marriage, when things really flipped in the country, and they flipped quickly, it was because of straight people who decided that gay marriage was not scary and that it was perfectly appropriate for the country we have become. And so my question to start us off, Melissa, is within this context, what do you think the role of white people is right now, and how do we inform and continue to engage white folks to be part of this conversation?
So I loved all of these pictures, and I really commend you on involving your children and having the conversations with them around these tough matters to discuss around race. And doing what you're doing is exactly what we need. You're listening to society, you're listening to people of color, and then taking it upon yourself to showing that you care. So my number one advice is ask about what communities of color need, and then speak up on our behalf, because it's going to take all of us working together to really change the issues that we're facing today.
How are you finding, we talked a little bit about ahead of this, about your kids and your own personal experience with race. How are you finding the ease of conversation in the professional workplace today? How does it compare to a decade ago? And are we moving forward in the professional setting, or how is this playing out there?
Absolutely. So, as I mentioned before, one of our initiatives is addressing and building an inclusive culture within the company. And this takes practice. None of us have been used to be able to talk about race at work. It was something that we just never did in the past. As a basic scientist, I certainly never brought my Hispanic culture, my race into the lab, never did it at work. But now the culture is, let's have open conversations. Let's make sure we're addressing employees' concerns. Only can we, when we are our whole selves at work, can we bring everything into the workplace to really change healthcare and change the dynamic.
I want to jump to our second slide here. This is one that you've brought to the conversation, Melissa. Why don't I let you walk us through what is here and what Genentech is doing in this space?
So the reason I chose this slide is because it does a really nice job highlighting another one of our initiatives, which is advancing inclusive research. So there's 3 key points on this slide. And the first is that we are a country of rapidly changing demographics. Currently, there are 5 states, as well as the District of Columbia, where we have a minority-majority population. And by the year 2045, we will be a country with a minority-majority population. The second key point is there are well-characterized disparities in both genomic and clinical research. In fact, 90% of genomic material that is available to scientists is of European ancestry. This is the source material that scientists use to develop new innovative treatments. If it's from European ancestry, we are not then adequately reflecting the genomic material of the rest of the world. Another key point on this slide is we know there are existing healthcare disparities. For example, Black women have a 41% higher breast cancer mortality rate than white women. And yet, Black women only represent 6% of women in clinical trials. These numbers are also the same trend amongst Latinas. This is really concerning to us because we can only advance science and advance clinical outcomes for patients if they're represented in clinical trials. And so we aspire to change that. We want to bring communities of color into clinical research. And the first thing that we realize we need to do to address this, this is really concerning to us.
Let me pause you there, Melissa.
Sure.
Ben, welcome to the show. We're going to have to take a minute to frame you in, but if you could mute your speakers, or rather mute your microphone for a second while we get you squared away, that would be fabulous. We're getting a little bit of audio. Does that make sense, Ben? Well, Melissa, let me turn it back over to you, Melissa.
So we aspire to achieve this by first and foremost listening to patients. As I mentioned before, it's really important to stop and listen. We're asking patients, by engaging with communities of color, what do you need? What have your experiences been with healthcare to date? What have the obstacles been that have kept you from participating in clinical research? And most importantly, how can we help you overcome those obstacles so that you can participate in clinical research and understand the value of cutting edge research and how it could benefit you and your family and your community?
So, Melissa, this slide, it's a pretty powerful one in that I hadn't really realized. I guess maybe I could have. I just hadn't thought about how little diversity there is in the genome data, particularly for folks, who are, when we're testing for vaccines and for disease mitigation. What do you think this means for the kinds of testing in the vaccine space, particularly since we're talking about that now and related to COVID? What are the concerns that arise for you as a research scientist about the homogeneity of the genome data here?
It's very concerning. We already know, based on the limited data that is out there, there can be differences in safety, efficacy, responses, appropriate doses when it comes to certain medicines in specific patient populations. As a woman of color, I want to know that my genetic material, people like me, are being considered when they're developing vaccines and future medicines, so that I can have more faith that treatments that I might need today or tomorrow will be adequate for my type of response.
And it looks like we may be able to bring Dr. Ben Danielson into the conversation now. Ben, can you hear me okay? Might have to take a
Yes, I can. Can you hear me?
Yeah, let's see if we can see up on the screen. Chan, our rock star video producer, is doing a lot of stuff on the back end. I appreciate you making time. I know you had, as I understand it, a patient matter, and we think that patients are more important than our stuff, but we appreciate having you here with us now. Why don't I just give you a chance, Ben, to introduce yourself and tell our folks. I mentioned to Melissa, we have people from Texas to Alaska on this show today. So tell us a little bit about the work you do.
Well, thank you for the invitation to be here. And I guess everybody has to take their turn being the show crasher for a Zoom meeting these days. So I'm glad to have my chance with 500 or more people that I've never actually met. But I'm honored to be here. I'm Ben Danielson. I'm a pediatrician. I work at an amazing clinic in the Central District in Seattle. This serves mostly low-income families. 80% are on Medicaid. And we serve a pretty diverse community. And we see the ways in which social factors, life factors, health factors, and contemporary issues like the coronavirus really impact our communities in intense ways.
Yeah, very good. I appreciate you making time, Ben. And appreciate those of you who are following along. One of the quirks of modern technology is that people have different download capabilities and different upload capabilities. And so the conversation that I'm having is going to be delayed between 2 seconds and sometimes up to 2 minutes, depending on folks' download capabilities. If you ever have a problem with your your experience, the best thing to do is just try to refresh your screen, and usually that will help things out. Of course, also, please be sure as participants that you post your questions on the chat, and we'll make sure that we integrate those into the conversation. I want to switch now to our next slide that you brought here, Melissa, and give us a sense of some of the work that Genentech is doing, specifically trying to not only address the issues that you just brought up, but also to meet this moment in terms of building an anti-racist culture at the company.
Absolutely. So to meet all of these challenges, we recognize there needs to be change, and that needs to start with change within our company. And so we have done quite a bit of work changing across the company as well as our clinical research departments in order to have a more real world population, more community of colors in our clinical research programs. We've carefully looked at our guidance documents and revamped them. We've revamped our inclusion exclusion criteria and clinical protocols. Do you realize that there are baseline lab values included in most clinical trials that are based off of, again, Caucasian populations? And yet minorities have different baseline values, serum creatinine, for example. So we need to make sure that we're not prohibiting patients from being in the trials by not having the right inclusion exclusion criteria. We're making sure we're looking for sites that have access and trust and community outreach to communities of color. And we realize that there are patient out-of-pocket costs that can be prohibitive to participating in clinical research. And so we want to work on making sure that we can address those. And across the company, we're making sure that we're not doing this in a silo. We're working with external partners to develop strategies. One of the best parts of my job is I get to work with an external council of esteemed researchers, advocacy leaders, and really gather their insights about the external landscape and how we can address some of the needs that they are very well aware of and entrenched in. As I mentioned before, we have the right support, which is essential. We now have dedicated headcount to really focus on these strategies. And we're making sure that our stance is known publicly on our social media platforms, in our corporate giving strategy with a real focus on health equity, and just making sure that people understand we need to collaborate across the healthcare industry to really move the needle in this space. We can't do it alone, but we want to be strong partners in this initiative.
I have a question for you, Melissa, specifically to some of the comments you had on your last slide. Sulani Madsen, who writes a column for the Spokesman Review in Eastern Washington, asks about the lack of diverse genomic material and how it's affecting research into COVID-19 treatment specifically. And she notes that, of course, COVID-19 is hitting non-European ancestry patients harder. So how is this impacting the COVID-19 research specifically?
I think all of us are still grappling with that very question. It is no doubt that communities of color have really been impacted. And just this weekend, I was reading the newspaper, and it really frightened me when they list the risk characteristics for having severe COVID-19 responses. And being a person of color is on that top 5 list. What is going on? There's obviously a lot of systemic issues that we need to figure out and really figure out how to approach this. As part of the initiatives around this, we did set up a COVID phase 3 trial with the sole focus of providing access to underserved patients and minority patients. So we sought out cities. It started in New York, inner city New York City hospitals, and then expanded it because there was such need across the United States and on the global arena when it came to people of color and COVID. So we're starting to peel away, and I hope to tell you in a few months, as that data starts coming in, that we have a better sense of what were some of these baseline issues that have really come to light.
So Ben, you and I think, talked about a little bit of on an aha moment when we reviewed that slide from Melissa that showed so much of the genomic material and research comes from folks who are white. What are your thoughts as you hear this conversation that's really upstream from the clinic about how the healthcare system is trying to grapple with some built-in bias that's not intentional, but it just, it or may be intentional, but I don't think in this case it's intentional, but may influence your downstream clinical experience. What are your thoughts when you see these slides?
Well, I guess I go through a couple of different places, and I think the question that was asked was really understandable. And I also want to make sure that we're not starting to say that there are actually significant genetic differences between racial groups, which are mostly socially applied labels and monikers. I do think about the genetics piece from a perspective of the experiences that become imprinted on our genome through generations, and how that tends to affect the opportunity for well-being, the wearing effect on subsequent generations, and the what's commonly called epigenetic impacts of living through a lot of stress, trauma, and different kinds of toxic exposures for generations and generations. Layer that in with a lot of the social dynamics. Who are the essential workers? Who are the folks who are being placed in higher positions of risk, and some of the other features? And I think you start to see this picture start to come together.
That's a good segue into the slide that you have brought to our conversation. This is it's a good one, and it brings an aha moment, or brought one to me. Why don't you walk us through the graphic that you've brought to the conversation?
All right, this is an anti-nerd moment for me, because usually I'm my bars and graphs kind of person for most of my presentations, but I wanted to share something that is maybe provocative, maybe thought-provoking, or maybe just something everybody knew already. When I started doing pediatrics, I was really focusing in on this child, like that one in the upper right, and thinking about how to promote their health and well-being in the best way possible. But as I started to think about it in practice, I really started to consider the experiences that child was having as a baby, and then I started to think by extension the experiences that child had as a fetus, and in its growth in mom's womb. And then I started to think about the factors that went into that pregnancy, and I just kept going upstream, and I came up with my own little mini aha moment that for half of that child's genetic material, it was really produced in a way by grandmother. We all know that women are born with all of the eggs that they will have in order to create new life. And since those eggs are born with mom, and mom was made inside grandma's womb, the eggs that mom has were actually made inside grandma's womb by grandmother. And it made me really have this aha moment about this 2-generation connection between even the genetic material, not just the spiritual and loving and social connection, but this very direct half of your genetic material connection between a grandmother and a grandchild. And this is true for all of us. And I think it creates this sort of special perspective on our generational approach to problems that we're seeing in front of us today. If we don't understand how we're connected generationally, even through our genes, then I think it's going to be harder for us to solve some of the most important contemporary problems that we're seeing in the lives of the folks that are around us today.
I will admit that after we talked about this last week, my wife and I geeked out on it a little bit and posited that maybe even it goes one generation farther upstream, that if adverse childhood experiences dictate much of the quality of your health over the course of your life, and those adverse childhood experiences are often things like whether your mother is safe, whether there's physical violence in the home when you're a child, whether it's drug use in the home when you're a child, but the quality of your childhood, particularly those first 5 years, and the health of your mother in those first 5 years, and how well your mother can take care of you, seems to me maybe even to extend this one more generation, that it's the grandmother's mother in those first 5 years that will, and her safety, if she's safe, then the child will be better off over the course of her life. It reminds me of. I'll come back to this comment here in a second. Melissa, I want to get your thoughts on this slide and whether you had an aha moment here or not.
Yeah, as soon as we discussed this slide last week, I called my mom and told her the story because it is such a powerful thought. And my grandmother and my mom are two of the strongest women that I know. And it just really made me stop and think, like, everything that my grandmother was going through when she was pregnant with my mom, advanced age, high blood pressure, 9 children. What impact did that have? And it's just, it's such a beautiful thought. And so I really started thinking about resilience in women and how it impacts all of our lives. So, yeah.
I'm reminded, Ben, when I brought when Kariana, my wife, and I brought our first child home, and he was a little guy, of course, and we had friends over, the first friends who came to see him outside the family, and my friend said, DJ, you just got to know this. There are two people in your kid's life, and this is their whole life. There's mom, and there's not mom, and you're not mom. And your slide reinforces that I'm not mom. How does this inform? There's a question from Shay Cheka about bringing about social and economic equity to healthcare in general. She's talking about professionals and lower wage jobs, and I want to go back to that here in a second. But I'm wondering if you can speak to how we support moms, both through policy, but through our organizations, and the kinds of conversations we should be having, particularly within a racial context and a context of racism in our society. How do we support moms within that context to address or learn from this slide?
Well, I think there's a number of different ways we can start to maybe just expand our beginning thinking about these issues and move ourselves from looking at one person, one generation, and really think about that more broadly. Indigenous peoples often have constructs of ideas around 7 generations: a grandmother, a mother, a child, that child's next 3 or 4 generations afterwards. And when you start to think about that, it pulls you a little bit away, doesn't it, from our maybe our political cycles that look at 4 years or 2 years or 6 years. It maybe pulls us away from what it means to have a timeline for change and improvement.
Yeah. Let me ask you, Dr. Ben, to respond to this question from Fathia Abdi, who asks about the 2 pandemics the country is currently navigating, and what discussions are you having within your own organization, or would you encourage amongst organizations related to the rethinking of the delivery of care, access to care, social determinants, and working within this sort of existing reality of racial disparities?
It's a great question. Do you think that's maybe appropriate for the next slide, the second slide I brought? Because it might add some context.
You bet. Let's bring that next slide up.
Again, a simple slide with some simple concepts to me. But when we talk about rethinking how we approach wellness and illness and the factors that may be playing into it, I've really come to start to think about these 3 overlapping spheres and how they impact well-being across generations. There's a sphere of economic alienation and the lack of opportunity for some communities to experience economic wellness. And as I mentioned to you 2 earlier in our conversation, what a very wise mentor taught me once as a pediatrician is that you can't educate an uneducated child. You can't educate an unhealthy child, and you can't keep an uneducated child healthy. And what that implies to me is the deep, deep interstitial connection between education and health and well-being, especially from a pediatric perspective, but I think across the age span. Our opportunity for health is so deeply tied to our opportunity for economic stability that those are inextricable. In addition, we have factors of toxic stress, which anyone, regardless of income, station, or race or ethnicity, or anything else, can be exposed to. Those toxic stresses are things that I think we're all experiencing in deep ways right now, and understanding the ways in which an acute toxic stress like this COVID pandemic is affecting our bodies, our wellness, our day-by-day health is an important lesson for us to carry forward when we think about the way we structure our healthcare system in the future. I think most people listening to this conversation would agree that a deeper expertise in sleep alone would probably do a lot to improve our health in general during times of stress. And then this added factor of racism and oppression. Racism, which is in so many ways the most foundational and oldest component of bias and discrimination that we've seen as a nation, and then the oppressive components that come from many different groups, from ageism to LGBTQ rights to disability rights, all of these factors kind of combining into those circles. It's important to know that I think for communities of color, they're often experiencing those three at the same time. It's important to know that sometimes there's two or three playing more of an important role. And I believe that we have to be very clear that when we're solving for one, we don't necessarily solve the other. So you can lift up economic empowerment to a community, but you also have to address issues of racism and oppression. We know, for instance, from the maternal mortality of African American women, that you can have a college education, you can be Michelle Obama, and the chance of dying during pregnancy is still 5 times higher for a Black woman than it is for any other race. So we have to really understand how to both see how these factors interact, especially for communities of color, and then also start to think about how the individual solutions are specific to those individual spheres themselves. I think we really need to rethink the way we talk about healthcare as an integrated component of all of these social dynamics and these generational factors, and really be thinking about that when you're training someone like me to try to be a good pediatrician in a community that I adore.
We're with Dr. Ben Danielson, medical director at the Odessa Brown Children's Clinic, and Melissa Gonzales, Dr. Melissa Gonzales, PhD, with the Chief Diversity Office at Genentech. Let me ask you both, as a white man, I get all of these benefits that I don't even know that I get from a system in the United States that has been built with white men in mind, usually and sometimes exclusively. What is your advice to people like me, who look like me, white men who don't have as big of a vocabulary as I would like? I grew up in a relatively white community in rural Central Oregon. Live in Seattle, which with the best intentions has sometimes a very segregated community. What counsel would you give to me about how to be a better anti-racist in this time? Melissa, what do you think?
So I said it earlier, first and foremost, be willing to have the dialogue and really listen. It's okay if you don't know all the right words, but let your friends know, your community know, communities of color, you want to listen, you want to hear their perspective. And then make sure that if you hear others making disparaging remarks, that you won't stand for it. It's only together that we can really become each other's allies. And when others realize that yourself, you will not tolerate them making off-the-cuff remarks because you don't believe in that and you don't believe in a society where that continues, that will go miles.
Yeah. Dr. Ben,
Beautiful.
how about you? What advice would you give me?
We bring to mind a couple of things. Number one is being in a position of wanting to learn, which is the way you just showed up in that question. I think is just so important. A foundational component of cultural humility is wanting to learn yourself, listening to others with the deep intention of learning and growing and changing. And that is actually something humans aren't really always good at. It takes actual cognitive intention to learn in that way, and to even to present yourself asking the question in the way that you did. So I think that's a very important component. Secondly, I think that in these conversations, it's important not to become afraid and to sort of close in on yourself. These are issues that are uncomfortable and difficult. There are places in which we all face sometimes being maybe simultaneously in a position of privilege and a position of maybe oppression of different kinds. And it's important to recognize that some of these ideas really translate across a lot of different kinds of, I'll just call them identities. And we don't do ourselves any service by suddenly separating ourselves from each other when there are things that we really understand about each other. a rural community challenge can be so very similar to what someone from an inner city may be talking about. And the opportunity to collaborate and talk about solutions between circles like that, that is powerful. And I guess the last thing I would say is that all of us have a responsibility around language, and I disdain the language I used a few years ago. It's constantly evolving. You and I talked a little bit about how I used to say racial disparities or differences due to race, when what I think we all recognize now are actually racism disparities and differences due to racism. There's language that keeps evolving, and I don't want to be afraid of embracing new language. I don't want to be I don't want to be someone who would shame someone else for using language that might not fully and appreciate this moment we're in compared to some years ago. So how do we have conversations where we accept people where they are? We seek to learn and grow ourselves. We create places where we bridge our ideas and our concepts and our themes and our ideas together as allies. And then how do we have forgiving but collaborative conversations that challenge us to grow a little bit more, but also allow somebody to make mistakes? What's it like to say, I made a mistake, and someone to allow you to keep moving forward?
Yeah, I think that's an interesting segue to this question that Keith Monosky asks, who says he's not a member of a minority population or a population that's being discriminated against, but he wants to paraphrase his question a little bit. How does he contribute something to the conversation, even though he's not a minority? How does he contribute to the conversation in a way that is a meaningful contribution and is respected, even though he may not have the experience of being a person of color? Any thoughts on that, Melissa, about how someone who's not a person of color can engage based on their experience in this discussion?
Yeah, I think it's fair for everybody to want to engage in the dialogue. That's how we keep the dialogue going, as long as we're all listening, right? And sharing perspectives. I'm sure he's had some perspectives throughout his life that all of us can benefit from. So we shouldn't shy away from it and say, well, just because, I haven't felt that specifically, that's the only way we're going to learn, is just being honest and saying, what do you think about this? We shouldn't shy away from it.
Yeah.
I guess I'd also add just that person may be in conversations that I would not have a chance to be in, and Melissa would not have a chance to be in. And so that opportunity to be in the moment of a conversation that a lot of other people would not have access to is actually a really powerful opportunity. And I think to see that as a chance to help broaden a conversation, help build a sense of understanding, that's actually really, really challenging, important work. And there are things that somebody might say to him that they might not say to me, and that we would never have the conversation around otherwise. That's really important. And I really appreciate the work of people like Robin DiAngelo at the University of Washington, who are sort of having conversations between white person to white person about topics like this that have a different character in some ways than the conversation when maybe I'm speaking to someone.
One of the things, Melissa, that I think I was certainly raised with, I think some other people in my Gen X cohort were raised with, which is that my boomer parents thought they were teaching me to be a progressive by teaching me to be colorblind and raising me to be colorblind. And it was only after a lot of conversations with friends and people of color that I learned that wasn't fabulous, that actually robbed me of tools to be able to understand and love my friends. So when you hear that white people say I'm colorblind, or maybe it's not even just white people, maybe it's other people too. When you hear that people are colorblind, how do you respond? How does that make you feel as a person of color?
So I've had this exact discussion with one of my best friends, and I told him, can I be totally honest with you and tell you what it sounds like when I hear you say I'm colorblind? And he said, sure. I said, it sounds like you only see the parts of me that make you comfortable. You don't want to see the whole Melissa and acknowledge that she is a minority. And so it seems like it's just a term that makes you feel more comfortable so that you don't have to see the whole person. And it took him aback, and he said, that was never my intention. And I said, I know, but because you're my friend and we've got that history, I'm comfortable telling you that's what it sounds like. And I know also as a student, that's a huge issue. I come from a family of public educators, and they've said we can't talk to students by saying, we can't have teachers that say we're colorblind. We all have cultural issues that are part of our whole selves that need to be embraced so that we can learn more effectively, so we can communicate more effectively. And so I think it's important to take away the colorblind, but be able to tell people in a gentle manner, like you said, Ben, that, maybe this isn't how you intended the comment, but this is how I hear it. And I think once you share that in an open and honest manner, people really learn.
Melissa, I want to stick with you for a second. Ashley Durkin asked a question that you touched on in your slide earlier, which is about racialized medicine and how that approach, which she says has proven problematic in patient care delivery, how that concern and those problems become manifest and mitigated when we're talking about genetic differences amidst mostly Caucasian genomic data used in research. Can you touch on that a little more? I know Ben spoke to it a minute ago, but I'd like to give you a chance to dig in there.
So as a scientist, I still think this is an area definitely of exploration. So yes, genetic sequencing has shown 99% similar. But I also know that when I was doing research, we know that genes are expressed differentially. And so we need to look more into how are genes expressed. Maybe the genes are the same in you versus, myself, but am I expressing a certain signal transduction pathway 10 times faster than you are? So there's going to be little differences like that, possibly, that we need to still explore, but we don't know if we can't explore it. And so, I realize it's sensitive subjects, but we need to continue investing in it so that we can really start to understand it from a scientific perspective as well.
Yeah, good. I want to go back to this question that Shay Cheka asked Ben and have you follow up on it. She was asking specifically about healthcare professionals in lower wage jobs and how do we go about bringing social and economic equity to healthcare when we've got professionals who, as people of color, are often in the lowest earning cohorts in the healthcare system. Thoughts or observations on that topic?
Just, it's such an important topic. I remember this was a little bit ago, but there were some sources that were tracking, I'm sorry for this topic, but the deaths of healthcare related workers during the pandemic. And it was shocking to see, especially in different parts of the country, the number of Filipino women who were among the casualties, who worked in some of the lesser paid positions in healthcare, and the diversity of death of healthcare workers is broad, is enormous compared to the diversity of the workforce of physicians, say. And that's a really telling statistic to me. The things I think we need to think about are how do we support people across the healthcare spectrum who are doing this kind of work and are often doing the most important parts of work in the least paid positions. I think that we have to really confront some of what's been a history of healthcare. I believe we talked about this once before, but around how deeply hierarchical our healthcare system is, and how much we treat people very differently based on the letters after their name. And we have an opportunity maybe to reframe some of our relationship to specialty in healthcare and talk about really where different people add such incredible value to providing wellness and well-being, and how we separate that from titles. I think we also, in a hiring practice, maybe really it's a good opportunity to think about what is the level of degrees or the level of qualifications that need to be in order to have somebody be in a position in the healthcare system. We've hierarchized that very strongly in the past. And I think we can start to rethink that. I'm sorry for short on time. I won't keep rambling, but
No, you're
I think
good.
that's just a space for us to just, we have to look in the mirror and really start asking ourselves, what are we doing to contribute to this state that is around us? And what is the state around us contributing to the things that we don't like about our own healthcare system?
I want to go back to our first slide today for this last question for both of you. And I want to go back there because this slide gives me hope, in part because those kids take after their mother, thankfully, the kids in the middle, and not their father, who is me. And also that the manner in which things change so quickly on the topic of gay marriage as demographics took over and opinions shifted in this country about 8 or 9 years ago. So let me ask you both, and I'll ask you first, Melissa, what gives you hope right now in America or in healthcare, given all of the things that could make us down in our news stream these days? What gives you hope?
The hope that we're having honest conversations now about the fact that there's been a history of racism, that we're seeing health equity issues now as a result of that racism, and the call to action to really invest in a future where we can stop this, where we can make communities of color feel welcomed, where we can invest in new talent pools with more minorities to serve communities of color. And it's just really hopeful to me that we're finally being honest and making plans about how to address something that we can no longer ignore.
Ben, same question. In this crazy time, what gives you hope?
First of all, your patience with me getting onto this call gives me hope that there's always room for patience and conversations. Secondly, I think that I just love what Melissa said. And it's interesting that you use that example, because I really do believe that when we see ourselves expanding the way we're thinking about things from one perspective, let's say from gender affirming practices, then you start to see how that opening up of your mind could have great applications to ableism or ageism or racism. And so I think that makes me very hopeful about opening doors, cracking those doors, and really getting people into the idea of, wow, we made this change. We made gender equity an important part of our physical space in our hospital. What else does that make possible? So I love the idea of, I guess you'd call it intersectionality or something like that. I'd probably use something more simple, like just opening up your mind, just getting a little aha about what's possible when you see something happen. I also have seen some tangible changes, some decisions and some policies start to happen that are meaningful. And so I love the dyad of seeing a street painted with Black Lives Matter. And I also love that that's not the end of the conversation. It's not creating performance art, but it's actually being accompanied by changes in our policies and practices to make sure that I had a 1 in 3 chance of being in prison as a Black male growing up in this country. I have a 1 in 1,000 chance of dying by police gunfire in this country. And the idea that we're looking at those issues in the context of health and starting to look for solutions that each of us can own, like we all have power in this, is really, really inspiring to me. And I can't wait to see how far we can reinvent ourselves, rethink ourselves, evolutionize, maybe even revolutionize the society around us. I'm excited for that. I'm excited for what I see every day in the clinic with young kids who just expect something to be different. They're not even asking or trying to get into that space or wondering what the next steps are. They just absolutely expect for me to be part of making something different, and then for me to get the heck out of the way and let them take the charge. That's inspiring every day.
Dr. Ben Danielson, Medical Director at the Odessa Brown Children's Clinic, and Dr. Melissa Gonzales, part of the Chief Diversity Office at Genentech. Thank you both for participating. And for those of you on this conversation with us, I appreciate your participation. we'll send you an email, as I mentioned at the top of the show, asking for your feedback. I'd love to get that. It helps us as we continue to move incrementally forward in bringing us this experience and convening in a space, a safe table here in these times of COVID. Love to have you continue these conversations with us. You can sign up for future virtual conversations at stateofreform.com. Thanks, everyone.
Thank you.
Thanks for joining us in this virtual conversation and for your support of our work at State of Reform.